Hi, so this is a new platform doing my Instagram live through YouTube, but I think there's lots of advantages why hopefully it will help. So I thought today, because it's Endometriosis Awareness Month, that I would talk about endometriosis, but also include adenomyosis as well. These are both incredibly common, but actually very misunderstood conditions. So if I just break down endometriosis first, it basically, in women who have endometriosis, there's tissue that is the same as the lining of the womb, which is the endometrium, elsewhere in the body. So every tissue, every organ has characteristic cells, tissues that make up that organ, and they respond to different circumstances, so different hormones, different conditions. The cells are all very specific. So if I did a biopsy, like took a piece of someone's heart, it would look very different to their bowel, for example. So the lining of the womb, the endometriosis, and the endometrium, the tissue like that can be elsewhere in the body with people who have endometriosis. Now, we don't know why this happens. When I was a medical student, I was taught that it was what we called retrograde menstruation. So we were taught that because rather than the blood coming out through the cervix, through the vagina in periods, it goes up through the fallopian tubes and up out to the rest of the body. That's since been dismissed, but we don't actually know why people have endometriosis. Now, some people might have some of the tissue that's the same as the lining of the womb growing in the wall of the womb, in the myometrium, and that's often referred to as adenomyosis. So it's very common often, or it can be common, for people who have endometriosis and adenomyosis together. So essentially, when I talk throughout this Instagram live or this YouTube, when I'm talking about endometriosis, I'm often including adenomyosis as well. Now, we don't know quite how common endometriosis is because for so many women, it can take years for a diagnosis. And even then, there's no quick diagnostic test. So it's probably more common than we realize. Some studies have shown it's about 10% of women, 1 in 10 women have endometriosis, but it could be more than that. We don't really know who's more predisposed to endometriosis or why people have it. But sometimes the tissue that's like the lining of the womb can be on the other pelvic organs. So it could be on the fallopian tubes, it could be on the ovaries, it could be on the vulva, it could be on the vagina, it could be on the urinary tract as well. But we also know that some women have this tissue elsewhere, on their diaphragm, on their lungs, on their bowel. And so you can imagine people's symptoms can really, really vary. Now, I want to show you a graph, which I have shown you before. This is showing how our hormones change throughout our menstrual cycle. And this one here is one that you might have seen quite a few times before. So day 1 is when people have their period. The middle of the cycle is often when people ovulate, produce an egg. And then this is day 28. So this is if someone had a 28-day cycle. Obviously, everyone's cycle is often quite different. But this is the red is the level of estrogen, and the green is level of progesterone. This one actually shows what really happens with progesterone because the scale is very different. But essentially, there's 2 things that's really worth looking at here. The first is in the middle of the cycle is when we ovulate, produce an egg. And what happens is both estradiol and progesterone increase. Now, this is relevant because some people get pain in the middle of their cycle. And then look, in the second half of the cycle, there's another peak of estradiol, but then this progesterone actually goes really, really, really high and then drops very quickly. So this is important as well because some people find that their pain, their symptoms of endometriosis or adenomyosis can worsen at various times of the cycle. Now, usually what happens when we have our cycle like this, the lining of the womb builds up in the first half of the cycle, ready for an egg to implant. So if we have an egg that's released and there's sperm around and it gets fertilized. Then the second half of the cycle, the fertilized egg embeds in the womb and a pregnancy starts. Now, for most cycles, there isn't a pregnancy, there isn't a fertilized egg. So the thickening of the womb, if you like, shreds. And it shreds because of this drop of hormones. And that shred of the lining of the womb ends in a period. So when we've got tissue that's in the lining of the womb in the right place, the endometrium, you can quickly visualize, hopefully, that the lining of the womb builds up and then shreds. So it's dynamic all the time. The lining of the womb is changing. But if you've got these cells elsewhere in the body, in areas that don't normally respond to hormonal changes, it can cause symptoms, especially if it's in a small area. So, for example, my husband recently saw a lady who has got endometriosis affecting her urethra, the tube that you wee out of. And at certain stages of her cycle, she was getting incredible pain and discomfort and bleeding passing urine. The rest of the time, she was fine. And it was only because he took a really detailed history, he realized there was a cyclical nature to her pain, the pattern of symptoms, and deduced that she had some endometrioid tissue around her urethra, and he removed it, and she's been pain-free fine since. So any cyclical changes in the tissue elsewhere in the body can cause symptoms. Now, the commonest symptom that people with endometriosis and adenomyosis get is pain. But people can also get bloating, they can feel sick, they can feel really awful as well. And anybody knows that when you're in pain, it can really floor you. It can really make you feel very down, very low, and can affect you systemically as well. A lot of people find that their symptoms change. So people might start with a few symptoms and then they might worsen. They could improve with time, but often people, when they have got more extensive endometriosis, when it's elsewhere, then the pain can be in other places. And some people get referred pain. So people sometimes, for example, have a lot of pain in their pelvic area, but it can radiate down their legs, for example, or up their abdomen. Now, it's can be very difficult to diagnose endometriosis because the gold standard, if you like, would be looking inside everybody and seeing if you can see these endometriosis deposits throughout the body. Now, it's not very easy, is it, to open people up all the time? And lots of people get period pains, they get bloating, they get discomfort. And it wouldn't be practical to look inside everyone's abdomen. Some people do scans. So the scanning, ultrasound scans are getting more and more sensitive, and some people can have a diagnosis by scan, but a normal scan doesn't mean the person doesn't have endometriosis. Adenomyosis can sometimes be picked up by an ultrasound scan or an MRI scan, but sometimes we can't pick them up. So like I say, normal scans don't mean that someone hasn't got endometriosis, but a scan suggestive of endometriosis or adenomyosis actually can be quite helpful for many women. There isn't a blood test that we can do to determine it. So it's often from careful history taking, seeing how symptoms change throughout the month, and sometimes a diagnostic test as well. But there are a lot of women who, when you go to different forums and read, are just not being believed at all. The pain that they're getting, sometimes associated with nausea, vomiting, feeling quite unwell, is often dismissed, especially if they've had normal scans. And we know that a lot of women aren't listened to during menopause or perimenopause, but a lot of women, the stories of women with endometriosis are awful, actually. The most important thing for me as a doctor is to listen to patients, understand what's going on, and really help them to try and make a diagnosis and a treatment plan that's right for them. So when we're thinking about treatment for endometriosis, people have differing views. Someone said a while ago, if you have 10 doctors in a room, you'll have 11 opinions. And that's because a lot of our opinions about treatment come from evidence, if there is good, robust scientific evidence. It will come from guidelines, if the guidelines are up to date and non-biased and using good, solid evidence, but also from clinical experience as well. So those of us that have more clinical experience often will tailor, or will have enough experience and knowledge to tailor a treatment in a very individualized way, rather than maybe, well, years ago when I was a junior doctor, I didn't have the experience and knowledge and confidence to manage people the same that I do now. So people's experiences of endometriosis will be different. Their treatment plans will be different as well. So I'm just going to give very generalized advice here. Obviously, I can't give individual advice, but I've really changed, actually, my opinion about endometriosis after the last few years of seeing a lot of women in my clinic. Now, you can imagine this hormonal change, it's quite rhythmical, and people who are younger, their symptoms can sort of change, but they sort of can be more predictable when they're having regular periods. Obviously, in our clinic, we see a lot of people who are perimenopausal, and the hormone levels are changing very quickly. And that can cause a myriad of symptoms, but worsening often of endometriosis and adenomyosis, because the tissue that's elsewhere outside the womb can respond to these changing hormone levels. Now, people often, when you read about endometriosis, will say that estrogen is really bad, because if you think about, like I said, the first half of the cycle, estradiol is building up the lining of the womb. And so some people think, well, if we block estrogen, then endometriosis will go away. So some people, or many people, many gynecologists, GPs, and other doctors will give the contraceptive pill. And what they're trying to do then is smooth out this graph, so the hormone levels sort of flatline, if you like. Now, some of you might have heard me talk about this before, and I apologize because I will repeat myself, but there's a real difference between giving contraception and the natural hormones. So when people give contraception, what they're doing is blocking the natural hormones working in the body. They're giving a synthetic type of estrogen and a synthetic type of progesterone. Or if it's progesterone-only pill, it will just be a synthetic type of progesterone called a progestogen. But whatever they are all chemically modified, so they won't work the same way as our natural hormones. Our natural hormones, estradiol, progesterone, and testosterone, are very anti-inflammatory. They reduce inflammation in the body. They work on our immune cells that fight infection and determine how we respond to any inflammation going on in our body. Endometriosis can become quite inflammatory because of this buildup of the tissue. So suppressing this change in hormone levels, often people find they have symptomatic relief. What I'm not convinced about, and I haven't read good studies to convince me, that suppressing the pain definitely suppresses the endometriosis. And what we do know is some of the synthetic hormones will increase inflammation in the body, because the synthetic hormones actually can become pro-inflammatory. They can change the way our immune system works, so there's more inflammation in the body. And we don't know whether giving synthetic contraception will actually increase severity or amount of endometriosis in the body. Just the studies haven't been done, so we don't know. So in my mind, it seems very simplistic, just trying to smooth out the hormones, make them very low. We know that obviously that can help, but increasingly in the clinic, we see people who are also perimenopausal, so they're also experiencing many other symptoms as well. And so if we just reduce their hormones by giving them synthetic hormones, they're not going to improve their other symptoms, and we're also not going to improve their future health. We know that when people are perimenopausal, this reduction in hormones will actually lead to health risks as well. So in the clinic, we often give the natural hormones. But what I've learned over the many years really of practicing medicine is that women with endometriosis often find that when they have the right balance of the three hormones, estradiol, progesterone, testosterone, it can really calm down their endometriosis as well as helping them to feel better as well. Often I will give progesterone and testosterone first before estradiol, because testosterone and progesterone are very anti-inflammatory. Progesterone is very calming throughout the body as well. It doesn't work just on the womb. It can work throughout the body. And what we don't want is this big rise up and down of the progesterone. we want it to be smooth, but rather than it being low smooth, actually higher smooth can be very good for the body. And so I know it's a bit of a mind shift for some people to think about, but giving the natural progesterone, but also thinking about giving estradiol and testosterone to those that are deficient in testosterone can really make a difference actually for the way people feel systemically, but as well with endometriosis and adenomyosis. Now, when we give hormones, when people have endometriosis, I'm often start at a low amount and gradually increase. Because if I give a level that's too high, it could flare up that endometrial tissue. So you want to do it very, very gradually. And often we'll give the progesterone all the time, because if we give it for 2 out of 4 weeks, which we often do in perimenopause, it can often mean that the endometrial tissue is still cyclicking and responding. So it's better for the women often to have like the same amount all the time. We know that estradiol, the natural estrogen, is very anti-inflammatory, whereas when we give estrogen in the contraceptive pill or with oral HRT, it gets converted to estrone, which is pro-inflammatory. It increases inflammation in the body. So metabolically, they're very, very different in the body. And I'm sure they're very, very different in endometrial tissue as well. And that is very important, because I see a lot of women who tell me that they felt worse when they were given contraception or they had the progesterone-only pill, and they're very cautious about starting natural hormones. But natural hormones can be very, very different. We know that testosterone levels start reducing in the usually late 20s, early 30s and decline with age. We know testosterone works throughout the body. We know that it works throughout the pelvic organs, including the endometrium as well. And increasingly in the clinic, I see women who have endometriosis and adenomyosis, and they have low testosterone levels and they have symptoms of testosterone deficiency. Adding back that testosterone often can help improve their pain of endometriosis. And wouldn't it be great if there were some good studies looking at women with endometriosis and looking at how their disease improves, or not, as the case may be, with natural testosterone and also natural progesterone. Now, some people with adenomyosis and endo as well, actually, respond with having a Mirena coil in. So the Mirena coil is a synthetic type of progestogen. It's a low dose and it gets concentrated in the womb and the surrounding tissues. And so some people get a huge relief with it, and that's because it's giving a constant progestogen. It's helping to reduce the sort of fluctuations of those hormones stimulating the endometrial tissue. Some people find they get side effects with it because it is a synthetic progestogen, but it's worth considering. Increasingly, I see women who have a Mirena coil in, and if it suits them, that's fine, but I will often add in progesterone as well. And there are 2 ways of having progesterone, either orally or as a pessary. So that's usually vaginally, but it could be rectally as well. And that's the pure progesterone. If we take it orally, then it does get metabolized into other products, because anything we put through our mouth gets metabolized through our liver. So if it's given as a pessary orally, a pessary either vaginally or rectally, it gets absorbed through the mucous membranes as the pure progesterone. And a lot of people find that can be very good in women with endometriosis. And increasingly, we can give higher doses of progesterone to really help keep that that inflammation at bay and reduce the inflammation that's associated with endometriosis and adenomyosis. The other thing that's very interesting about the natural hormones, estradiol, progesterone, and testosterone, is they can modulate pain receptors. So anybody that has pain, not just related to endo or adenomyosis, people with any pain at all, often find that their pain gets worse before their periods when those natural hormones decline. And so we know that having those hormones back can actually help with the modulation of the pain receptors in the brain, but actually the way that the nerves work as well and determine and feel pain, if you like. So having, even if the stimulus is still there from the endometriosis, the perception of pain can be quite different when people have their hormones back. And so it is really important, because A lot of people I see who have endometriosis are given synthetic hormones. Then they're given painkillers, often quite strong painkillers, which then can cause side effects like nausea or constipation. People who have deposits of endometriosis on their bowel, they don't want to get constipated. It can cause the pain to be so much worse. So then they're taking laxatives. They might be taking anti-sickness. And so people have layers and layers of medication by the time they come and see me. And it's often gone on for many, many years. Increasingly, I'm seeing younger women who have recently been diagnosed. And I'm finding that trying to get on top of their pain with natural hormones, coming off their synthetic hormones that they have been had for contraception, actually for many women has been very transformational and really, really improved their symptoms. Anyone who starts hormones, though, it can take a while. So patience is really, really important. The other treatment that some gynecologists give is a treatment which can either be a tablet or an injection, or there is a nasal spray that block the hormones being produced. These are GnRH analogues, so they work on the brain that signals our hormones to be produced, and they basically block the hormones working. So it's really giving people a chemical menopause. So it's switching off all our hormones, estrogen, progesterone, and testosterone. And I sort of understand why people give it, and I sort of get really sad actually for those women that have those drugs, because when they have those drugs, it's switching off the hormones. So this graph of the hormone levels is just going to be really, really low. So there'll be no estradiol, no progesterone, no testosterone. You're just going to be like a menopausal woman. The endometriosis might be quite happy because it's not being stimulated by those changing hormone levels. But the brain, the heart, the body is not going to often thank you because it will cause a lot of symptoms. And I remember speaking to a lady recently who had been given these injections of Zoladex because she was waiting for some surgery of endometriosis, but there's a long waiting list. And she said, I've suddenly become stupid overnight. I can't concentrate. I can't think. I have such bad brain fog. I can't sleep. I feel like I've aged overnight and no one is listening. And this is because all her hormones will have been just switched off overnight with these injections, which I think is a very cruel thing to do. And we should be counselling people, telling people about this before just switching off their hormones. When people have injections such as Zoladex or some of these other hormone blockers, we can give what we call add back HRT. So we can give back estradiol, progesterone, testosterone in a natural way. So the hormones are exactly the same as the hormones we produce ourselves. And we can give them as a low dose, but it means that all those cells are responding to the hormones. You're still getting the benefit. But if we give the same every day, then it means that you're not getting this fluctuation. So that fluctuation when people ovulate, the fluctuation in the second half of the cycle won't be there if we get the right dose and type of hormones back. And that can be really good for people who have these blockers as well. There is a drug that came out recently that some of you have read about, probably in the UK. It's been out for a while for fibroids. And it basically is a tablet that contains one of these blockers, and it contains some HRT as well. But it's a very low dose of estradiol orally, and it's a very moderate dose of a synthetic progesterone called norethisterone. When I've read reviews of it, there's lots of case reports of people feeling absolutely dreadful on it. And I'm not surprised, actually. In medicine, you want to individualize dose and type of any medication for each patient. Giving like a 3-in-1 drug just doesn't make sense to me. I just think it's not going to be that helpful for the majority of people. The other thing is that when we give oral estrogen, it increases something called sex hormone binding globulin, which then reduces the freely available testosterone. So if a woman does have testosterone, that testosterone level is going to be even lower when she has this other medication, which is not helpful because testosterone, like I say, is quite anti-inflammatory, and it also can help with mood, energy, concentration, stamina, sleep, all the symptoms that many people with endometriosis and adenomyosis have. So we need to be thinking properly about hormones. Some people have surgery with endometriosis, and if it's extensive, then it can cause sort of adhesions and everything to be sticking together. So you can imagine if you've got some endometriosis deposits on the bowel and then it sticks to the womb, everything gets very stuck, very sore, very uncomfortable. And so removing the tissue can be very beneficial. What's also very difficult sometimes, though, with women with endometriosis is that you might see very extensive disease if you look into someone's abdomen, but they might have very few symptoms. Or the converse can occur, that people have very few deposits when you look in their abdomen or their pelvis, but they have a myriad of symptoms. And that's where often people aren't believed, because the surgeon will say, oh, it doesn't look like you had bad endometriosis, but the woman is crippled in pain. She's taking lots of painkillers, she's having lots of time off work, she's really struggling. And so we should not be judging people by how the endometriosis looks in a scan or with an operation. Every time people do an operation, obviously there are risks with any operation that any of us have, but also there can be adhesions that can occur, like scar tissue from anything that's removed. So it's important to try and see a surgeon who's very experienced in endometriosis. And certainly if the bowel or the bladder is involved, then it might be that a general surgeon and a urologist is involved in the surgery as well. Having the decision to have surgery needs to be done very carefully with the right team of people, and making sure you know exactly what the benefits are for having surgery. If you're going to have any of your ovaries removed, and even your womb removed, even if your ovaries aren't removed, then you will likely to have become menopausal earlier. So even if someone only has one ovary removed, the one remaining ovary might not last as long. If people have their womb removed, we know that people will, even if their ovaries remain, they're likely to have an earlier menopause at a younger age. So it's important before surgery to ask about, is this going to affect my hormones and can I have hormones back? Like I say, lots of doctors seem scared of having estrogen because they think it's going to flare up endometriosis. Quite a few people I see have been pregnant before, and one of the things I often ask them is, when you were pregnant, did your endometriosis flare up? And usually people say, no, it didn't. And that's often because of the levels of hormones, the natural hormones they had in their body. We have to remember that people, when they're pregnant, have high levels of natural estradiol and natural progesterone. And so we don't replicate those high levels when we give HRT, but it gives us confidence to get the right dose right. And that's really, really important when we're thinking about really individualizing care for women who have endometriosis and adenomyosis. So even if you have surgery, then we still will give hormones. Some surgeons say, look, I've got all your endometriosis is out, you only need estradiol. And that's what I used to do many years ago. But because of seeing so many people reading, trying to understand more about hormones, I'll actually usually still give certainly the 2 hormones, often 3 hormones to women, even if they've had a hysterectomy and they don't need progesterone for their endometriosis. Because progesterone is a really important hormone throughout our body, in our brain, our heart, our bones, our muscles, and so forth, people get a lot of benefit often from the progesterone. And the same with testosterone as well. It can have many, many good effects. So balancing those 3 hormones can be really helpful for symptom control, for future health, but really important actually, and can help with endometriosis as well. When people have the natural hormones, they can still have painkillers, they can still have anti-sickness drugs, they can still have laxatives, they can still have antidepressants. But often we find that their need for these drugs reduces when they have the right dose and type of hormones. So people shouldn't be scared about having hormones if they've got endometriosis or adenomyosis. But one of the big things, I think, if you're a patient, you should be asking, if I'm having hormones, am I going to be having natural hormones, the body identical hormones, which are available on the NHS, rather than synthetic hormones? Because they will work differently in the body. Synthetic hormones or contraceptives will often increase inflammation in the body and may increase or worse than endometriosis. Like I say, we don't know too much because the studies aren't done. Wouldn't it be great to have some proper funding looking at the role of hormones, natural and synthetic, on endometriosis? But we know systemically in the body, it's always better to have natural hormones. It's better for our brain, for our bones, for our whole system, because our bodies are designed to have natural hormones, not the synthetic hormones. But it's just been the way that guidelines have been sort of written for many, many years, talking about blocking hormones for women with endometriosis, and only really thinking about blocking this hormonal fluctuation with the synthetic hormones. So we need to be thinking differently, I think, for women with endometriosis. We need to not be so scared of the natural hormones. We need to be thinking more about testosterone. We need to be thinking more about progesterone, especially the natural progesterone given vaginally and orally. And we need to be thinking more about the right dose of estradiol as well. So working with a gynecologist hand in hand with a menopause specialist can be very, very useful. And you don't have to wait till you're perimenopausal or menopausal to see a menopause specialist, because we're all specialised in female hormones. And increasingly, like I say, we see women who are young, who are struggling with their symptoms of adenomyosis and endometriosis with hormonal variation. And so sometimes if people have PMS, PMDD, and they have endometriosis that can worsen throughout their cycle, we might just give hormones for part of that cycle to try and help stabilize hormones. So there's always options, there's lots of choice, there's lots of things that we can do. But I hope that's just given you a bit of an overview, and I hope it's been useful for you. There is an article about endometriosis on the website, and we'll keep adding more and more information as we get more, but we just need more research, don't we? So anyway, I hope that's been helpful. Enjoy the rest of your evening, and thanks to those of you that have dialed in.